see. There we go. So welcome everyone. This is welcome to our scientific meeting today, which we are going to discuss cerebral functional analysis monitoring from a perspective of PICU practice. So presenting the teaching today is going to be my friend, my senior, and my consultant, some levels of my training, Omer Aziz. He's a PICU consultant in the Bristol Royal Children's Hospital in Bristol, and he's basically the lead on the CFM introduction to PICU in the UK so far as I know. You can correct me, Omer, but I know my thoughts is you started the whole thing. And he's got very good information and data. He's like the best guru on the subject. So yeah, I'll leave it to him now to lead.
So more correction was I lead on CFM in Bristol from that point of view, but I was trained in a children's intensive care in Birmingham, which use a lot of CFM, and hence why my experience related to it. So first of all, I'm going to talk about what's cerebral function analysis monitoring, okay, or what we'll also refer to as CFM, CFAM from that point of view. If you're looking at literature, it's also called amplitude integrated EEG. I can't see the chat, so please do put questions in there, and Ahmed will highlight those to me. I want to try and make it interactive as well, so just ask questions in between. I'll see if we can answer them as we go along from that point of view, but also we'll have time at the end. So what we're going to talk about is what is CFAM or CFM or amplitude integrated EEG? Why do we do it? How do we interpret it? And who do we use it at the moment in intensive care environment? So as I said, cerebral function monitoring, or CFAM or CFM, is also referred to as amplitude integrated EEG. Okay, so if you're looking at literature or looking for papers, then use either terms if you want to look at the relevant literature. So we know that actually in order to do a full head EEG, there's 12 different electrodes that are placed on the head that looks at electrical activity around the brain. And in order to actually interpret this, and certainly within the UK, there's people that actually spent years and years and years training and their job is to solely interpret neurophysiological sort of tests, including CFM. So we don't have that available 24/7 in the PICU, but so the next question is electrical monitoring of the brain important in the critical care environment? I'm going to try and argue why it is important and what evidence there is behind it. So clearly, if you don't have the full head EEG or the results immediately available, what's the alternative? So we can then change it to what we call the CFAM. So the CFAM is looking at just two electrodes, so looking at the right and left hemisphere, and because or for example, this entire EEG will take on this strip might take like 12 seconds, but if we're going to use EEG as a point of care for use by the intensivist, that's too complicated for us to analyze because it's reams and reams and reams of data, and we're not actually trained to do so. So we try to break that up into a lot simpler form, so actually the intensivist can use the CFM as a point of care monitor. So in order to make it simpler, we look at two components of the EEG or the raw EEG. Firstly, how fast it's going, or you can say the frequency. And secondly, how big or small the waves are, and that can be referred to as amplitude. So this is how it's set up, okay? Ignore the picture on your right for the time being. So there's essentially 1, 2, 3, 4, 5, 6 electrodes that are placed on your head. 2 of these electrodes monitor the left hemisphere, 2 of the electrodes monitor the right hemisphere. And then there's a reference electrode and an earth electrode from that point of view, okay? And that's important because then essentially you've got 6 electrodes on your head, or how the child or patient has on their head whilst we're monitoring this. as I mentioned, so there's two components of the squiggly lines or the waves of EEG that we look at. How fast they're going, and that is converted into a color scale. So the more red that appears upon the screen, the faster the activity of these waves. The second is called the bandwidth. So that's a marker of how it marks the highest point at which the amplitude is and also the lowest point. So it gives you an idea as to how big the waves are and how they are fluctuant. So, and that's what we broadly look at, and that's amplitude integrated EEG for you, because that gives you a quick sort of visual analysis of actually what's happening in terms of electrical activity in the brain. So this is what a typical screen might look like. Okay, so you've got what we call digital spectral array, or DSA, how fast the activity is on the right side of the head, and then the amplitude integrated EEG, or CFAM, how big or small those waves are on a particular side of the head. So the top might represent the left side and the bottom to represent the right side. So you've got and if you look at just one, if you just ignore the bottom half of the screen with the raw EEG, if you just look at the top half, that gives you a quick idea as to what your baseline activity is over the last 4 hours, okay, as to how big the amplitudes are or how fast or slow they're going. So just as a quick glance, that looks, for example, this looks at that actually the electrical activity is completely stable. It's not particularly fast from that point of view, and the amplitude is where we would expect it, anywhere between 10 and 25. Then if you scroll to a particular time point, then you can get the raw EEG, obviously, and the raw EEG, one screen of this represents 12 seconds. So you can see that in order to look over 4 hours, you have to go through a lot of data, but just a quick visual assessment allows you to be confident actually that the main thing is that this patient ain't having seizures or their cerebral activity is not markedly depressed, that you'd be worried about it. And then if you're particularly interested at a particular site or a particular time, then there's a cursor here, which is very light blue, might not be might not be able to actually see it. It is right at the left-hand side here. And you can scroll to that particular time point and see what the raw EEG is like. So if you suspect someone to have a seizure, you expect to have a rhythmical activity on the raw EEG and a rise in baseline. But I've got plenty of examples from that point of view, and we can go through those shortly. Okay, this is a bit slightly different appearance of the monitor, but exactly the same thing. All right, so why do we monitor? So the main reason for monitoring electrical activity on the intensive care unit is to screen for potential seizures. So the next question is, how many of our patients have seizures? So we know that post-cardiac arrest, anything up to 40% of these patients have evidence of electrical seizures, okay? Post-cardiac surgery, so Bristol is a pediatric cardiac center, and probably 2/3 of our patients have a cardiac history or are post-cardiac surgical, and 1/3 of those patients have, if we monitored all of those, 1/3, that's 30%, have evidence of electrical seizures. Post-ECMO, or what's an ECMO, you have 20% seizures, and actually there's a huge amounts of, so for those that may not be familiar, ECMO is extracorporeal membrane oxygenation, so essentially it's bypass for patients who need cardiovascular support. That is that's beyond sort of inotropes from that point of view. Okay, and so if you look at the literature, one of the most strongest prognostic markers from a neurological outcome for patients on ECMO is actually raw EEG. Because we know that these patients are at higher risk of bleeds, higher risk of getting some thrombotic events as a result of being on ECMO. Okay. Post TBI is traumatic brain injury. So we know 30% of those patients have evidence of seizures. Okay, if you look at abusive head trauma, okay, 50%, and actually more recent data indicates that 75% of post-traumatic head injury, so those, for example, shaken babies, have evidence of seizures. And there's some animal models to suggest that actually if you treat these seizures aggressively in terms of completely suppress these seizures, the extent of injury that these children suffer, or the neurological sequelae as a result of the abusive head trauma, is far less. Okay, so those are the evidence of electrical seizures. Okay, ignore the last bottom bit. That was just some data from Birmingham. Okay, so you say, okay, so you got evidence of electrical seizures. What next? Does it affect outcome? Now, if you look at the literature itself, then it's varying in terms of the reported outcomes with use of CFAM. There's some evidence in the sort of top half which indicates that actually use of CFAM reduces the amount of cerebral injury or cerebral neurological sequelae as a result post, whether it's cardiac surgery or neonatal hypoxic ischemic injury. However, there's also evidence that actually doesn't make any difference. Now, my argument is that, for example, on your intensive care units, you have standardized monitoring anyway. So for any patient on an intensive care unit, you would monitor EEGs, you would monitor things like oxygen saturations, for example, you monitor blood pressure. Now, if you're going to look at the evidence for monitoring, that's actually really difficult to then demonstrate outcomes as a result of monitoring, because it's not the monitoring that actually affects your outcome, it's your intervention, surely, isn't it? So actually, for any monitoring tool, for example, I would challenge you to provide me evidence to show that on an intensive care unit, there's evidence that you need to monitor SATs. Obviously, we need to monitor SATs because that's what we do, and that's ingrained in our practice. From that point of view, it provides us information in terms of assessment, and I'll be worried for any sort of, especially a modern day intensive care unit that doesn't monitor SATs, because that's one of the things we can adjust in terms of oxygen and such like, rather than just being reliant on our eyes to see when a patient is hypoxic. But if you look at the evidence per se, then that is very limited, because that actually, for any monitoring tool, it's difficult to develop the evidence base. So if you want to strictly look at the evidence, then that's really difficult. So that's one of the arguments, and I completely recognize that. But I think for a monitoring tool, it's really difficult to actually develop the evidence base. So neurointensive care in any intensive care is actually, it's quite difficult, because there's increasing recognition that in order to provide effective neurointensive care, it requires multimodal monitoring of neurological function. Okay. Often our patients on the intensive care unit are sedated, muscle relaxed. So we're very limited in terms of neuro monitoring. So we can be reliant on their pupillary size from that point of view. But other than that, how are we supposed to detect any one seizures or any sort of significant neurological sequelae? My thought process, or my argument, has always been that the CFAM is not the only modality. It's just a small cog in the bigger picture of neurointensive care, where actually it's one of the components that's used to provide further information about the neurological status of this sedated or muscle relaxed child that's in front of you, who might be at risk of seizures. The counter to that, and I completely recognize it, is that people say that if for example, if we're saying here that post-cardiac surgery, 30% of these patients have evidence of electrical seizures, I completely agree that not all of these need to be treated, but actually recognizing that there are a component of patients who have electrical seizures. Whether that makes any difference to their outcomes is really difficult as well from my point of view. But certainly in the UK, so for example, more mortality from PICU on average is what, 2 to 3%. Mortality from cardiac surgery is typically 1 to 2%. Okay, that's mortality. But if you look at neurological morbidity, i.e. the neurological sequelae of either PICU or actually cardiac surgery, that's huge from that point. And so we need to be better in terms of multimodal monitoring of neurological status of our patients, because that might then provide some information about preventing long-term neurological sequelae or neurological injury. And so, again, CFAM is one component of that in the bigger picture. Okay. So hopefully I've kind of made an argument why why CFAM should be one of the components that we monitor in a neurointensive care. So how do we do it? Okay, so how do we go about actually monitoring this patient? So say, for example, we've got this patient coming in who is on, I don't know, who's had a cardiac arrest at home, has got return of spontaneous circulation, and has been brought into your intensive care unit. In order to maintain neuroprotection, we will continue to sedate them, muscle relax them from that point of view, maintain their parameters like the CO2 within a particular range, the glucose within normal range, make sure they don't get pyrexial. And then we apply the CFAM. So it's CFAM, a lot of it is about pattern recognition. And one of the biggest issues about use of CFAM is that it's subject to artifact. And given that it's a point of care instrument rather than, and we are not experts in the intensive care unit in terms of interpreting EEG, one of the biggest issues is that actually what might be artifact, we might misinterpret as EEG, and that has potential downsides to it as well, because you don't want to be escalating anti-seizure medication when in fact there's artifact on the monitor is what you're seeing, and that's what we need to first of all recognize. So typically our bedside nurse might actually recognize that there's a change in CFAM, escalate it to the medic who's on the shop floor, and the first thing I would suggest that our fellows do is look at the impedance. The impedance is how well the stickers are attached to or electrodes are attached to the head, such that if they're not attached adequately, you might get an inaccurate sort of signal, as a result of which you might misinterpret it as a seizure. For example, like I'm sure we've all seen it in terms of a SATS probe not being attached properly, and the SATS number that you're getting is not actually accurate reflection. The first thing you want to do is not necessarily jump on treat the potential hypoxia, but you want to make sure you know what's happening with the SATS. You would change around the SATS probe, attach a new SATS probe, similar sort of concept, okay? And then it's about pattern recognition to see exactly what's happening with the CFAM, whether these are seizures, whether the normal sleep-wake cycling. Again, I'll show you some examples of this. If there's an abnormal activity in the background, and then what we're going to do about it, and how we're going to review the CFAM after that. So what we tend to do is the first thing, as I said, you check the impedance as to how well the electrodes are attached to the brain. And there's a button on our machine which says impedance. You basically press it and you expect all of these bars to be green. If they're not green, then it means that they're not attached to the scalp appropriately. So you just reattach themselves, ask the nurse to reapply them, and then reassess the CFAM. I say it's about pattern recognition, similar to how you would interpret an ECG. You look at it, you recognize a pattern, and then you make an assessment. And so that means that you have to look through a number of these in order to make a diagnosis. So so I'm just going to go through some examples, okay? The first one is, so what you're looking at is you come and look at the screen. As I said, the top half of the screen, this represents 4 hours of EEG monitoring, okay? And you look at if there's any any significant sort of fluctuations in the baseline of the CFAM or the amplitude integrated EEG from that point. And as with this one, you can see it's fairly stable in terms of baseline. You can get occasional dips and rises from that point of view, but there's no massive up and down. And the bottom trace here, there's a slight dip here, but we'll talk about whether that's just sleep-wake cycling shortly, okay? And then you look at how fast it's going, and you can see it's going at a steady rate. There's no massive sort of jumps in how fast it's going from that point of view. So I would classify this as a normal CFAM. And then you can scroll it to a particular activity, and you can see this sort of random squiggly lines from that point of view, rather than any rhythmical activity, which would suggest seizures. So again, I mean, this is appropriate label. So this is again a normal CFAM, although you can say that there's some fluctuation. So this sort of undulating appearance of the baseline, that is seen as a result of the patient sort of sleep-wake cycling from that point of view, and so you can see it's just sort of naturally just curving up and down from that point, okay, and this is actually a good prognostic indicator post cardiac arrest, for example. So equally, it's important to recognize, but you wouldn't treat these as seizures. Whereas this is, you probably be able to appreciate there's a sudden rise in the baseline here, okay, and that's represented that suddenly the size of the waves have massively increased, okay, and if you look at the red, the DSA, there's a sudden rise in red. So not only have they gone faster, but they've actually increased in the amplitude as well. And then if you scroll to this particular area, okay, then oops, sorry. And if you scroll to that particular area, you see in the raw EEG, which is at the bottom, there's this rhythmical activity, okay? And so that would be indicative of seizures. And just by looking at this sort of very sort of broadly, you can see that this patient has been having, if the top strip represents 4 hours, over a period of 4 hours has had 1, 2, 3, 4, 5, 6, 7 seizures from that point of view, each of which were lasting a significant period of time. So then the question is that significant in this particular patient? Do you want to treat it by escalating your anti-seizure medication? This is again more evidence. This again, I will show you a number of different examples of CFAM and how they might be interpreted. So if you look at the bottom sort of scale, the CFAM, there's that sharp inflection point, okay, which is a lot more sharper compared to the original sleep-wake cycling, and so that makes you suspicious. And what it's also associated with is a rise in the red color, which means that again the amplitude has increased in size, but also has the sort of frequencies. They've gone faster and bigger from that point. And it's predominantly on the left side. But if you look at the top side, i.e. the right side, there's a slight dip in there as well in terms of slight rise in the baseline. So this is, you can be confident in saying that actually this is a left-sided seizure with secondary generalization to the right. Okay, so that gives you, so for this completely sedated and muscle relaxed patient, it gives you some indication of what's happening in the head in terms from that point of view to make you the diagnosis of potential seizures and what you would do about it. And someone's quite rightly pointed out that the focus is on the left side here from that point. Okay, so again, you might get occasionally with any seizures in a completely sedated child, you might get some physiological indicators which might say, okay, like pupillary changes or a change in the heart rate or blood pressure, which might make you suspicious of a potential seizure. But this provides electrographical evidence of that. Okay, so can anyone put in the chat what do they think of this in particular? Obviously, it says isoelectric at the top, but what might this be caused by? I'll give you a few seconds to write something down. Coma. Anyone want to explain anything else in terms of coma? Most of these patients are essentially in a coma because they're sort of sedated, so we're on a lot of sedation and muscle relax. No fluctuations, brain death, sedation. Yeah, excellent. Okay, so it shows that actually the electrical activity in the brain is extremely flat. And if you look at, so if you look at the top 2 lines, they're extremely flat and you can't see hardly any red in it at all, okay? It's all completely blue, so they're really slow, okay, and extremely flat. And then if you look at the raw EEG, it's almost completely flat. And you can see these slight blips here, okay, which actually, and the bottom, this red line here is representative of an ECG. So actually these slight blips are actually picking up the ECGs. The brain activity is so flat, it means that actually it's picking up ECG activity, okay? And this can happen in a number of different situations. So you could be on so much sedation that you causing isoelectric EEG. So you might want to consider coming back on your sedation. Someone mentioned brain death. That's another particular interest of mine from that point of view, and that's a whole different talk. So I don't necessarily want to go into that too much. So, and if you got completely flat EEG like this on someone who hasn't got any, who's not on any sedation or anything like that at all, it would make you suspicious of whether you've got brain death or not. or death by neurological diagnosis as the more modern term, but you can't diagnose it just based upon this, if that makes sense. But it would make you suspicious of that. So again, it's a useful piece of information that might not be otherwise available. Okay. This is called, again, these are labels, so the answers are really obvious. So burst suppression. So burst suppression, as it suggests, is there's periods of complete suppressed activity, which is completely flatline, and then there's episodes of burst. Okay, can someone in the chat again say when you might see burst suppression? I'll give you a few seconds to write that down. I haven't got any responses, so I'll talk through it. So burst suppression, sorry, HIE. Yeah, so you can get it in HIE. So burst suppression can be one of two situations. Burst suppression can be as a consequence of any cerebral insult, such as severe hypoxic ischemic injury from that point of view, and the brain is completely suppressed, then has occasional bursts of activity, then completely suppressed. However, in certain patients, we want to achieve burst suppression. In terms of trying to get, so for example, a patient comes in with status epilepticus, okay? We intubate and ventilate them, we increase their sedation, keep on increasing their sedation, they continue to seize. So we continue to increase their sedation and anti-epileptic medication until they get to the point of either burst suppression, where they're no longer having seizures, or to the point where their seizures are controlled. So one of the two. So burst suppression might be a therapeutic goal in, for example, a patient with a difficult to control seizure activity, or if you want to completely suppress and rest the brain, or it might be as a consequence of the hypoxic ischemic injury or any other injury to the brain. Okay, and the reason, and if you look at the raw EEG, it has it's really broad bandwidth, because you have what it marks is this really low amplitude and then this really high amplitude. Okay, so if you look at the bandwidth, it's really broad. Okay, so as I say, this bandwidth is really broad because it's got really low activity, really high activity. Okay, Um, and then what we try to, when we try to make sure that when, for example, we have a patient with status epilepticus who we want to get into burst suppression, what we try to do is get one episode of burst in this 12-second window. So if we're getting completely flat, okay, that means we're giving too much medication, so we need to come back on it. So we try to achieve at least one burst in every raw EEG when it's the therapeutic goal. If we're getting too flat, then we get this tooth comb appearance, which means that actually there's less than one burst in the raw EEG. So we need to again come back down on the medication. Again, this is an completely abnormal CFAM. So you got these episodes where there's sudden rises in your baseline, and that would indicate status epilepticus. So you need to escalate, and that's also associated with a more redness in your DSA, which means that your amplitude is higher and it's going faster, and you'd be suspicious of seizure activity. So you escalate your appropriate anti-seizure medication, whether that's midazolam, phenobarbital, or whatever other or thiopenton, whatever you're using from that point of view, until that's controlled. Okay, then here is that broad bandwidth. Okay, so it means that, okay, probably you've achieved burst suppression. That's good. So you stop seizure activity, and then you get this episode where it looks a bit more tooth comb appearance. Okay, and you think, okay, probably am I overdoing it in terms of the anti-seizure medication? You might come back then, and then there's this sudden inflection point again, which might indicate a breakthrough seizure. So again, you adjust your medication. So hopefully this, although slide demonstrates how you can use CFAM in a real time-sensitive way to adjust your medication to control electrical seizures. especially during the middle of the night when you don't have a neurophysiologist available and you don't have access to EEG services. Again, this is another example of seizures. So there's that sharp inflection at the start of the CFAM from that point of view. You might adjust your medication, get to burst suppression from that middle bit where it's really broad width. And then again, you might get breakthrough seizures as well. So you can adjust your medication in real time rather than being reliant on doing an EEG during office hours, which is then interpreted, which takes another couple of hours. So this allows you to assess the neurological electrical activity in real time and actually respond to it. As I was saying, there's sometimes we see some physiological changes in a child who's, like, for example, a traumatic brain injury that has come in, who has spikes in the ICP. And one of the questions always raised is, can this be a seizure activity? And there's no way of actually telling because there's no other changes from that point. But if you got the CFAM on, then you can say, actually, there's no generalized seizure activity, and you can be confident in that just by the use of CFAM. Again, this actually is quite a nasty CFAM because the underlying activity is so suppressed, so low. But then when you're getting activity, it looks like seizures. So this is brain is very much sort of compromised from that point of view. So it's either seizing or completely flat. Again, this is demonstration of someone who's having regular seizures. So those sharp inflection points are indicative of electrical seizures. And then you need to make a clinical decision. Are those significant? Do you want to treat them? As opposed to this one's a bit more subtle. So again, you can see where the red arrows are. Those sharp inflection points actually are representative of seizures from that point of view. There's a sudden rise in your baseline, indicating a rise in your amplitude, and that corresponds to an increased redness on the DSA. So again, the waves are getting faster and bigger, which then means that actually those are seizures from that point. And on this side, it's predominantly on the right side, but there's occasional sort of generalization to the left. Again, this is a patient who's in status. You can see those sharp fluctuations with increased sort of fluctuations in the redness from that point of view, indicating seizures. Again, this is an isoelectrical EEG. If you're on massive amount of sedation, you might be achieving this. For example, if you're on a significant amount of thiopentone, but also if you got significant impairment of the brain from that point of, say, for example, a significant prolonged downtime if in out of hospital cardiac arrest. As someone already mentioned, someone who might be dead by neurological criteria, might have a completely flat EEG. So it's again using this to provide some context to the clinical picture. And I mentioned right towards the start that one of the things is artifact. So you can see, if you just ignore the bottom half of the screen, you can see how those inflection points at the top, you might think, okay, is this patient having a seizure? But then if you look at the raw EEG at the bottom half, actually that doesn't show that sort of rhythmical activity, but these spikes that you see, it's very abnormal from that point of view, but that's not cerebral electrical activity. That's actually muscle artifact. So we tend to muscle relax our patients, or patients who need CFAM typically are muscle relaxed from that point of view, because it's important to recognize what is artifact and what it's not, because what the last thing you want to do is escalate your anti-seizure medication for these patients when actually what you're seeing on the EEG is actually artifact and not actually seizure activity. And similarly, this also shows some artifact. Again, it's completely abnormal. It's literally all over the place, but the electrodes were plugged in the wrong way around from that point of view, and that was the result of what you're seeing from the screen. So it's what we tend to teach is that actually interrogate what you're seeing, make sure the quality of the tracing is adequate for you to make a clinical diagnosis, or use that to make a clinical diagnosis. So the next question is, who do we put our CFAM on? So we put it on for obviously any patient who's intubated and ventilated with ongoing status epilepticus, or who's got encephalopathy, post-cardiac arrest patients, ECMO patients, because we know that they're at risk of having seizures and cerebral sort of dysfunction, and also traumatic brain injury as well. Okay, let's stop sharing.